Good morning. I welcome my co-instructor and faculty for this surgical management of pediatric cataract video-based learning. This is an instruction course, and we have with us I am Dr. Jagat Ram, and I am former director PGI and former head department of ophthalmology PGI Chandigarh. And with me, we have Dr. Jaspreet Sukhiza, who is professor, and he deals with pediatric and neuro-ophthalmology and strabismus service. He is chief of the strabismus services at PGI. We have Dr. Parul Chawla Gupta. She is additional professor. She does cataract, cornea, and refractive surgery at PGI. We have with us Dr. Savleen Kaur. She is associate professor, pediatric ophthalmologist, and pediatric and neuro-ophthalmologist, and deals with the strabismus patient. And we have Dr. Love. He is the founder and executive director of Netralem at Kolkata, senior consultant, pediatric ophthalmology, cataract and refractive surgery, former assistant medical director of Shankara Netralaya, Kolkata. And we have the keynote address of Dr. Sarijna Adhikari. She will be speaking on dealing with inflammation in pediatric cataract surgery. I will give introduction later on. And introduction to changing paradigm of pediatric cataract surgery. When I joined PGI in 1979, that time pediatric cataract only, I think needling was done. Many of the doctors, they used to do only needling, and leave the no aspiration was done. But later on, it was realized that it took a long time for absorption of the lens matter, and then we started doing needling and aspiration. It was just with the Simcoe cannula or like that aspiration. So lot of complications such as PCO, no IOL implantation that point of time. Then 10 years later or so, started with extracapsular cataract surgery and small incision cataract surgery. And there was no much trend of IOL implantation into these patients. Then 1995 onward, we started doing phaco aspiration. There was a trend of continuous curvilinear capsulorhexis, and also came this primary posterior capsulotomy and anterior vitrectomy for younger children. And later on, a little later, about in 2000 or so, we started implanting toric IOL into these patients. And 2010 onward till now, we started doing phaco aspiration, and with all these primary posterior capsulotomy, anterior vitrectomy, toric IOL, ADOF IOL also, and we also carried out fematocataract surgery. So there is a lot of change which has taken place, and the videos. This is a video based, so most of our faculty, they will be showing videos. I will request Dr. Parul Chawla Gupta to speak on basic step of pediatric cataract surgery for a novice pediatric cataract surgeon.
Thank you so much, sir, for the opportunity. Please put the PPT.
Each of the talk is for 11 minutes, and then we will have a discussion on each of the video presentation.
Good morning, one and all. I'll be starting with the instruction course. So, surgical management of pediatric cataract, video-based learning. So, basic steps of pediatric cataract surgery for a novice pediatric surgeon. So, congenital cataract has a worldwide prevalence of 4.24 per 10,000 people, with the largest prevalence in Asia. It is one of the most important treatable causes of child blindness. So, what should be the timing of cataract surgery? Bilateral should be done around 6 to 8 weeks of age and unilateral around 4 to 6 weeks of age. We must remember that there are increased rates of postoperative glaucoma in the first 4 weeks of life. How should we make the incision? A superior clear corneal triplanar incision of 2.2 or 2.8 mm is preferred, as the wound is protected by the upper eyelid from trauma. Scleral incisions can be used when opting for rigid PMMA lenses. And smaller, tighter fitting incisions help in the better maintenance and stability of the anterior chamber and minimize the times in and out of the eye. Two uniplanar 1 mm side port incisions, 180 degrees apart, give better maneuverability. How to address smaller pupils? Smaller pupils are less than 4 mm and they are associated with higher complications. They can be due to posterior synechiae secondary to uveitis, trauma, persistent fetal vasculature, or pupillary fibrosis. We dilate preoperatively with tropicamide cyclopentolate, or we can use intracameral adrenaline, or now we have intracameral mix of adrenaline, lidocaine, and phenylephrine. So why anterior capsulorhexis is difficult in children? It is thinner and elastic, it is convex shaped, it tears easily and runs peripherally. AC is shallow in a smaller pediatric eye. IOP is lower due to less rigid sclera, and there is poor red reflex due to opacities. So how do we do the anterior capsulorhexis? We can do a curvilinear capsulotomy. We can use a vitrector to do the vitreorhexis, 2-incision push-pull technique. We can use a femtosecond laser, or precision pulse capsulotomy, or plasma blade capsulotomy. And what are the tips? We should pull the anterior capsule centrally, use a cohesive viscoelastic, and should take frequent bites of the anterior capsule. A high molecular weight cohesive viscoelastic should ideally be used, as it flattens the anterior capsule and keeps the anterior capsule taut. Multi-quadrant hydrodissection is very necessary, using a cannula on a 2 cc disposable syringe, and at least 3 quadrants of hydrodissection should be done. Coaxial or bimanual irrigation aspiration should be done. Start from the periphery and swipe clean. IOL implantation should be done only after filling the anterior chamber with high viscosity viscoelastic. Push the leading haptic and then the trailing haptic. A single piece hydrophobic acrylic IOL is preferred due to less PCO and pigmentary deposits. 3-piece can be used in cases of PC rupture. Monofocal IOLs are preferred in children. Multifocal can be done in ages above 5 years of age with bilateral cataracts. Lens should be ideally a hydrophobic acrylic material. Peripheral iridectomy should be done in cases of aphakia, uveitis, trauma, with a vitrector, and if there is a bleed, then we can use intracameral air or epinephrine. Primary posterior capsulotomy and anterior vitrectomy should be done in all children less than 6 years of age, and just a posterior capsulotomy in less than 8 years of age. It can also be done in older children having nystagmus, or post-trauma, or having a posterior capsular plaque, and mentally retarded children. So suturing should be done in less than 2 years of age, as there is low scleral rigidity and increased elasticity, and there is a chance of wound gape. It can be done with 10-0 nylon or a vicryl suture. And finally, a preservative-free moxifloxacin should be given intracamerally. Subconjunctival dexamethasone can be injected, and we have also been using intracameral dexamethasone and triamcinolone intracamerally in children with good postoperative outcomes. Follow-up should be done regularly. Postoperatively, topical corticosteroids should be used up till 4 to 6 weeks, and topical antibiotics 4 times a day. Topical cycloplegics for up to 2 weeks, and a follow-up period with glasses and contact lenses and patching for visual rehabilitation. Now I'll come to some videos. Can you increase the music? This is a case of a pediatric cataract. We inject the trypan blue dye after making the uniplanar side port incisions, then wash it off. 0.06% trypan blue dye is used. Then we fill with viscoelastic, cohesive viscoelastic. Then we use the cystitome to start the capsulorhexis and complete it with the Utrata forceps. A multi-quadrant hydrodissection is done, and finally a bimanual irrigation aspiration is done. We should make sure to polish the capsule perfectly. because they are at a increased risk of PCO, these pediatric eyes. We are putting a 3-piece intraocular lens as the patient was not affording. Ideally, a single-piece hydrophobic acrylic lens is the best because it leads to least ovaling of the anterior capsule. And then we finally put sutures and air. This is another video in which we show we had put intracameral mydriatics. After staining the capsule, we put the intracameral mydriatics. That is a combination that is available nowadays. And you can see how beautifully the pupil dilated. The rest of the steps are same. We have to re-grasp the anterior capsule again and again because there is a tendency of going outside. Multi-quadrant hydrodissection as well as delineation is done. That's why we could see a small nucleus coming over in the anterior chamber. We can do a posterior capsulotomy initially, or we can do the posterior capsulotomy and anterior vitrectomy after we put the IOL. We should hydrate the side ports nicely. This is another video in which we used triamcinolone. You can see the beautiful lamellar cataract with riders. So congenital cataract is usually present at birth, though it may be missed. And developmental cataract is after 1 year of age, and it usually develops in the infantile or the adolescent nucleus. In this we have put a single piece hydrophobic acrylic IOL, which is the IOL of choice as it leads to less PCO, less pigmentary deposits, less Sine K. And finally we have put 1.2 mg per 0.03 ml of intracameral Canacot. This is another video in which we did rexes with a vitrector, as the capsule was very thick and attached to the lens matter. You can see the calcific plaques on the anterior capsule. We tried with a cystitome, but it was not possible. So we used a vitrector. The pupil was really small. So we need to use the vitrector at the cut IA mode. We make a nice opening of around 4.5 to 5 mm. The posterior capsular axis should be slightly smaller than the anterior capsular axis. But since we didn't have to put we have made a PI because the patient was left aphakic, as the corneal diameter was less than 10, or another indication is if the axial length is less than 17. So to summarize, congenital cataract is an important treatable cause of childhood blindness. It should be managed promptly to achieve good visual acuity. In the bag placement, along with primary posterior capsulotomy and anterior vitrectomy, is essential in the younger age group, and post-operative care and follow-up are inevitable to achieve a good outcome. Thank you.
Thank you, Dr. Parul, for your excellent presentation. I think you have covered almost all the basic steps.
Yes, sir. Yes, sir.
In the infant and children particularly.
Yes, sir.
When you apply sutures, you have some age group issue, or otherwise all patients?
Sir, less than 2 years, we prefer to apply sutures, either tenno nylon or vicryl, because there is they can be gaping of the side ports and the main port, and that can lead to ingress of fluid from outside and can further lead to end-offs also. So as the elasticity of the sclera is very less, so we should ideally put less than 2 years of age. But even in older children, if we feel that the wound is leaking, then we should put the suture. We should not hesitate to put the suture. So tenno nylon or tenno vicryl are good. And vicryl is absorbable, but it leads to slight amount of scarring and inflammation, more as compared to tenno nylon.
Any question from the?
Yeah, Those are very nice videos. Just wanted to know your preference for a single piece versus a three piece. Like, how do you decide when to do what?
So single piece IOL, hydrophobic acrylic IOL is always the best, but due to our children who are from a poor socioeconomic status, we tend to put more of three pieces, and three pieces are also more preferred in cases where we intend to do a posterior, where we intend to do a optic capture. So, or if there is a PCR, or in cases of posterior lenti globus, where the capsule is flappy and it has to be cut by the vitrector. So we tend to put the three-piece IOLs in those cases. But the fact is that the single-piece hydrophobic acrylic IOLs are the most biocompatible, and they lead to least ovaling of the anterior capsule rhexis.
Any relation to the visual axis obscuration between these two types of IOLs, three piece versus a single piece?
So hydrophobic acrylic as such, whether it is three-piece or single-piece, both have very less PCO as compared to PMMAs or silicone IOLs. But single-piece IOLs are definitely preferred, except where we have to do a optic capture.
And one last question, like, what are the conditions where you would not implant an IOL? Like, any situations where you would leave the patient aphakic?
Yes, sir. If the axial length is less than 17, some studies even suggest less than 18, or axial length, or when the corneal diameter is less than 10. So we try to avoid putting the IOL, and in fact we make a PI to prevent pupillary block glaucoma.
I think as far as three-piece versus single piece is concerned, initially we used to implant three-piece mostly. Now we are implanting more of the single-piece IOL.
Yes.
But as such, there is no change in the PCO rate when it is a square edge type of IOL, hydrophobic acrylic square edge type of IOL.
Yes, sir.
There are still many US surgeon and other, they still implant three-piece IOL. But as such, I think there is no change in the complication rates.
Yes, sir.
But I can say that a single-piece IOL should never be implanted into sulcus.
Sulcus.
Whereas I think we can implant three-piece IOL into sulcus
Sulcus,
in
yes.
case support is poor.
Poor. Yes, sir, definitely. It should never
Yeah.
be implanted because the haptics are broad. They will keep on rubbing against the iris. It can lead to UGH, uveitis glaucoma, hyphema syndrome, persistent iritis it can lead to. So three-piece are definitely preferred in cases of when we have to put the IOL in the sulcus. When the PCR is extremely big, we cannot put it in the bag. So we have to put it in the sulcus, and it is beneficial if we do a posterior optic capture. That will also lead to more stability of the IOL.
Any question from the audience? Any of you have any question? Although we will continue to deal with all the questions. Yeah, please.
So
Mic se le lo,
sutures,
mic.
should be put in children where they suture management. So we did a study in which we did early versus late suture removal of 10 nylon sutures. So one group we removed the sutures at 2 weeks, and another group we removed the sutures at 6 weeks. So we realized that the rate of suture complications like loosening, attachment of debris, and those other complications, suture-related complications, are more in the 6-week group. And so we concluded that even removing sutures as early as 2 weeks is good. And we also compared the integrity of the incision on AIOS2025. So that was slightly better in the 6 weeks group, but considering the disadvantage of the suture-related complications, we concluded that it is better to remove sutures as early as 2 to 3 weeks in children. And for vicarial sutures, we don't need to remove it, but they tend to attract more debris, so we need to follow it up closely.
Yeah, please.
So posterior capsule rhexis can be done with a needle bent needle cystotome like we do an anterior capsule rhexis. It can be done after aspirating all the lens matter and with the cystotome. But if we need to do it with a vitrector, we can do it after placement of the IOL. So if we place the IOL and then do the vitrectomy, you have a better control over the capsule rhexis, and there is more chance of placement of a single piece IOL in the bag if we do it after putting the single piece IOL.
I think as far as this posterior rhexis is concerned, first we give a nick with the needle cystitome and then try to make posterior rhexis with the utrata forceps. Sometime we may be stuck up. So in that situation, it is better to use vitrectomy cutter. That gives more stable if you are going out. So in that situation, I think you can use vitrectomy cutter.
So you need to put it in the cut IA mode. The vitrectomy cutter should be in the cut
Cut
IA
IA mode. IA cut is for aspiration. Cut IA means that you are cutting but not aspirating much. So with this, I think we go to the next presentation. It is extremely important. This is IOL power calculation simplified. This will be by Dr. Savleen Kaur. Dr. Savleen Kaur is Associate Professor at Advanced Eye Center, PGI Chandigarh. I think this IOL power calculation is one of the most difficult situation where what power to implant and how we calculate and which gives better results.
Good morning and thank you, sir, for that introduction. Because this morning we are talking about kids, and if we want to make our world better, we have to make it better for them first. So having said that, the challenges in IOL power are broadly classified into two aspects. We always have a confusion when to implant an intraocular lens in a child, and then if we decide that we have to implant, what power to implant. The decision of when to implant is largely based on the biometry and the age of the child, and the power would be based on the axial length keratometry measurements and what is the target refraction that you aim at. So I'm going to be talking about these 5 aspects and try to simplify it. The first question being when to implant an intraocular lens. The infant aphakia treatment study that has been, I think, recapitulated by Dr. Parul said that axial length more than 17 and a corneal diameter more than 9 with an age more than 6 months is your cutoff for intraocular lens implantation. But the other randomized controlled trials, and I particularly quote this one from the survey of ophthalmology, which describes all infantile cataract RCTs, and you look at all the RCTs and you see the numbers are the same as the IATS, but once you look at the visual axis obscuration, that is way higher with the IATS as compared to the other studies. So by and large, overall, the risk of visual axis opacification is more with IOLs, but the difference is less depending on what study we are kind of quoting and where we are from. So it's not that black and white a situation, you implant or not implant. And the consensus overall is for a child with a unilateral cataract, you have to go in for a contact lens or an intraocular lens. It's a better option vis-a-vis a child who's having a bilateral cataract. In the Indian context, we have studies by Dr. Jagat Ram where IOLs have been implanted in kids as low as 6 weeks of age, and a particular group of LV Prasad. And we have found that IOL implantation is possible in a select few cases who are less than 6 months, depending on how the compliance with the contact lens will be. So another viewpoint, I think it's a wonderful thought by Dr. Jaspreet, that if you have an age less than 6 months, look at the bag diameter. And this is a paper that we published recently, that the bag diameter might be a good indicator, even if you have an axial length and a keratometry reading that is not normal for that age or normal for that age, but the age is less than 6 months. Look at the bag diameter if you can with the ultrasound biomicroscopy, and if the bag diameter is more than 8 mm, you can go ahead and implant an IOL. Having said that, and once you've decided that you have to implant an IOL, we need to know what power to implant. The first aspect is the axial length, the most important. Now, the office measurement of axial length is very difficult in young children and adults and infants, and under anesthesia, you might be able to get a fairly good reading because you might have an eye which is straight. The errors in measurement will produce a greater error in the IOL power calculation. So you have the options of applanation and immersion. Immersion being giving us a slightly higher and correct, more accurate values if you have access to. In the office, the child is often crying and is up-rolling, so the readings might not be very accurate. And under anesthesia, you can ensure that the eye is stable and is straight. And you can take a good reading with a contact scan also, making sure that you don't indent the cornea. Now, you have to take multiple readings because the corneal compression is more likely because they're low scleral rigidity. And you should always have an instrument which has an oscilloscope screen if you can hear the sound of the video. These are spikes that you're getting, and you have to look at these spikes, whether they are coming from the lens, so that you know that you are looking at the correct exit length from the center of the eye. As far as keratometry readings are concerned, inaccuracies will produce errors up to 1 diameter in the IOL power. And for cooperative children, optical biometry is the best because that will give you the most accurate K reading, but it is not a viable option when you're dealing with infants. So you can use a handheld keratometer often when the child is sleeping, or in this case, you see the child is breastfeeding and we are taking a keratometry reading. In the OR, it's again, an more accurate method, ensuring that the eye is stable and central. And you have to ensure centration, which you cannot in GA, but you take 2 to 3 readings. Look at the standard deviation. It should not be very high, and all measurements should be within 1 diopter of each other. Most people like to take it as the first reading, even before you check an intraocular pressure, and take it without a speculum. Make sure the cornea is not dry to get an accurate reading. Now, again, which formula to use? You have an exit length, you have a keratometry reading, and you want to know which formula that you want to use. We are not using the regression formulas very often now, and again, we try to review what is the best formula that we use. People say use Hoffer Q. There's a group of people thought that, okay, it's a small eye, use a Hoffer Q, but it's not true. It's not small for that age. The child may have a normal exit length for their age. So there's no consensus because we are using all adult formulas, but the IATS has used Holiday 2 and SRK-T. These are the 2 most commonly and the most will give you the minimum error. Barrett Universal is also one formula that is giving us fairly accurate results, but no randomized trials in children using that formula. So you have the exit length and keratometry. You can choose and play around with the formulas that you have and look at the target refraction and then decide what power that you want to implant. The target refraction, we have said that, but we don't know what target refraction to aim at. You need to have an IOL power which is a balance of what the refractive error will be immediate post-op, and then it has to be no amblyopia in adulthood as well. So as the age progresses in a normal eye, an exit length increase causing a myopic shift is counteracted by the lens flattening and the flattening of the cornea. Now once you do a cataract surgery, you don't have this lens flattening component, and you also have done a cataract surgery, so you have induced some amount of astigmatism. So the exit length is not counteracted by further lens or corneal flattening. So it produces a myopia. Anticipating this myopia, you have to undercorrect the child, and how much to undercorrect the decision is based on the growth pattern. If you have a very small child, you expect a larger myopic shift. But if you aim for a very high hyperopia, you will get an immediate high hyperopic error, which will cause amblyopia. A very small hyperopic error will produce a myopic shift later. So the error should be small enough that you can correct it with the contact lenses and counteract the myopic shift later on also, so moderate hyperopia. Again, Dahans gave us some guidelines. If you use them, you will get a very high hyperopia of +6 or +8, especially when you're operating with infants. So it moved on to the Inyadi rule of 7, and we are following somewhat what Crouch et al. Gave, that a +4 refractive error in a child of age 1 and so on, to give us a sum of +4 or 5. We did a study again, IOL implantation in infants, where we used target of +4 in infants, and the myopic shift was over a period of 3 years was less than 1 diopter. The IATS used 8 diopter undercorrection for infants and 6 diopter for more than 6 weeks. So this is the age group. Still, there is no consensus, but by and large, bilateral cataracts +6 to +8. For a unilateral, you want to keep a little lower. So you have to consider the age at the time of cataract surgery. You have to know what the fellow eye is. If there's dense amblyopia and you have a unilateral cataract, a high hyperopia might not be a very good option. You have to look at the compliance of the parents for follow-up, for contact lenses, and in this era, we have a lot of parents with myopia, so we are expecting a more myopic shift. So the major challenge would be to the post-op refractive error, and it will largely depend on the IOL power that you choose and the target refraction that you keep. There are inherent difficulties, and it is crucial to obtain an accurate IOL power. You'll still get errors even if you use the most sophisticated instruments with you. You will always get one error, but try to make it a very small and a positive one. Thank you so much, Dr. Jagatram. We have been having this IC for the last 4 years now in a row. Thank you, Dr. Jasprit, my mentor, and thank you, AIOS, for inviting us.
Thank you, Dr. Savleen, for excellent discussion on IOL power calculation. Any question from the audience? Otherwise, what IOL power in day-to-day life, IOL power calculation you use?
Sir, we are aiming at a moderate hyperopia. So depending on the age and the laterality, I think these are the two most important factors. So if you have a bilateral cataract, you aim for a +4 or 5 in a child who is an infant. More than 1 year, you kind of follow the rule of 5. So you have a +2 at an age of 2 years, you have an IOL power, so on, a +1, say at age of 4 years. Earlier, we used to feel emetropization occurs at 7 to 8, so that's why +8 and 7 used to be the target. Now we are kind of aiming emetropia when the child is 4 to 5 years of age.
Yeah. Otherwise, when we started IOL implantation in children, we used SRK2 formula initially. And then later on, we switched over to SRK-T. And then looking at the studies from Dr. M.E. Wilson, he said that whether it is SRK2, SRK-T, holiday or other, there is no much significant difference in the outcome. That is in one of the study. But most of the time at present we use SRK-T.
Yes, sir.
And
Holiday. Absolutely, sir. Whichever formula we use, we will always get an error. We have to try to minimize the error that we get.
So yeah, that's right. Basically, in older children, you can just juggle around with the formula. You're doing an IOL master. The problem comes when the younger children, when you have to do a manual A scan, that is the time the issue comes up with calculation of the IOL power, because they are not fixating and you don't know where the axial length is going. So what the best, what I try to do now is do the biometry, hold the probe and see it under the microscope, because the indentation is the part which is going to create the problem. So you have, when you see your probe under the microscope when you're doing the axial length, probably you can be more accurate that time with getting you can say a closer axial length to the actual. The other thing is when you have those readings on the biometry, because of the issue of compression, you get 5 or 6 readings. So you take the reading with the maximum ACD, that's the anterior chamber depth. That's most important, not the average what comes down. So with that, you can basically get closer to a better IOL calculation using whichever formula you want to use, SRK2 or T, which have been there for quite a long time.
One thing for unilateral cataracts, the residual hyperopia, do you use something different when compared to a bilateral cataract?
Sir, for a unilateral cataract, I don't aim a +7 or +8, because immediately that child might not wear glasses, I might not be able to give them a contact lens. So +4, and my threshold is little lower for a unilateral cataract.
Just to reiterate, the prediction error of IOL power calculation will be maximum in children less than 2 years, or axial length less than 22, or keratometry more than 43.5. So we should always remember that in children less than having these criteria, there will always be a prediction error. Now we have to see which IOL formula will give the least prediction error. So we can use Dahan's, or we can use do a simple IOL master 700 biometry, and we can do 20% reduction in children less than 2 years of age, or 10 to 15% as was suggested by Prost up till 4 years of age, and 4 to 8 years of age we can do a 10% reduction. So that will give a fairly hypermetropic result, which will offset the myopia which will happen in the later years.
yeah, very right. Because initially when these formulas were not much there in 1997, Dahan's estimate came. With that it was almost a 20% reduction less than 2 year, and 10% from 2 year to 8 year. But later on we realized that it goes more into the myopic shift. So we adjusted that, and we reduced partly so that we may not get more hypermetropia, or we may not get more myopia ultimately over a period of time. Thank you, Dr. Savleen.
So we have another question.
Yeah. 10 years.
For 10-year-old, again, I would not keep the child, I will not aim at a very hyperopic error. They are already emmetropic. Emmetropia, and if I have to choose, like a little, like a 0.5 or something plus. Otherwise,
Yes.
emmetropic after, say, 8 years of age.
After 8 years.
I think,
Sir,
yeah.
what about, like, going on to that question, what about if you have a unilateral cataract at 10 years and the other eye is -6 from an ROP? Then what do you do?
So yeah, so
Other I know.
So unilateral cataract, again, we are talking about scenarios which are non-complicated. We are not talking about PHPVs and ROPs and, blue ophthalmic eyes. We are talking about, you have to take that into consideration, the existing comorbidities. So if you have myopia in the parents, you have myopia in the other eye, I am anticipating a bigger myopic shift. And a unilateral cataract, again, with the component of amblyopia, you can, I would keep a little plus, but not, because it's not going to grow much. The -4 to my mind will not be that amblyopogenic, the anisometropia. So yes, near work, again, there are studies of EDOF lenses, and Dr. Jagatram has a paper on multifocal IOLs in children more than 8 years of age. So again, very select few cases, no comorbidities, the perfect surgical technique, perfect rexes that you have. Sir has implanted even multifocal IOLs. I have done personally a few EDOFs. I think they do well.
Yeah, okay.
So, but then a personal choice if you
Dr.
want to go
Jasprit
ahead. But
Kibat?
I like to
Okay.
tell the child that child is I'm going to lose accommodation. For unilateral, the child is
Okay.
using the other eye, so I'm not that bothered with the accommodation.
Okay, Dr. Savlin, thank you
you.
so much. I think for 10-year-old child, what I do, I keep almost, if it is a E-metrop other eye, I try to keep it just E-metrop or so. Why? Because from 10 year to till 18 year child will be some little growth in the axial length take place that will make 0.5 to 0.75 myopic this child. But what I do, I keep emetropia at 10 year so that it may go a little myopic 0.5 or 0.75. Whereas more than 17, 18 year, we keep 0.5 toward the myopic side. 18 year because that is adult. So thank you so much. And now I will request Dr. Jasprit Sukhiza, who is professor and chief of the pediatric and strabismus surgery at PGI Chandigarh. He will be speaking on intraocular lens implantation in children, when and where to place.
Good morning to all, and thank you, Professor Jagatram, who was my mentor, for having me in this instruction course. And of course, he's a legend in pediatric cataract surgery, and we've all learned from him. So I would be discussing something about intraocular lens implantation in children. It's been very nicely covered by the previous speakers, and a part of this when to implant, as has been discussed in the previous talk as well. So we'll just go a little further, have some videos, and maybe some other points for discussion where probably people till now would not have implanted an IOL. So what are the indications for IOL implantation in children? Of course, this is universal. When your axial length is more than 17 millimeters, you have a corneal diameter of 10 millimeters or more. This is based on biometry, but then you based on age as well. So there is basically a consensus that below 6 months of age do not implant an IOL. And of course, based on other biometric factors, even if the child is above 6 months, then of course demographics has a big role, especially in the context of India versus the Western countries. So where to implant the IOL? Conventionally, what do we do? As has been shown very nicely in the videos, it's endocapsular implantation. So you would basically try and implant the IOL in the bag. That's the place which has been, we've been used to, and that's been described in literature and well studied over the period of years. The other thing which has come up recently is the optic capture. So basically all these things are coming up to prevent visual axis obscuration. Sulcus cases, it's a big no. very, very selected cases, maybe some older children. And of course, a bag in the lens, which is being done in Europe, and that's patented IOL. We don't have that in India as well, and it's really working wonders. So what is routine pediatric cataract surgery? I mean, routine pediatric cataract surgery is doing a primary posterior capsulotomy, doing an anterior vitrectomy, and placing the IOL in the bag. So basically, you do stain the lens here, the capsule in children, because of you need to decrease the elasticity, you have to have a good visibility. So having a anterior capsular access slightly smaller than the IOL optic is the optimal condition here. You can see the anterior capsular access, which is about 5 to 5.5 millimeters, and then you can do a manual posterior capsulotomy. So basically, you can start off with the needle, and you have a better control when you use an Utrata forceps, what you are doing here. So you make it about 3.5 to 4 millimeters, because the IOL has to go in the bag. So it should not be much bigger, otherwise you might have the IOL going into the vitreous. So we stained here with the triamcinolone, done just to stain the vitreous, because we need to do the anterior vitrectomy. So once you've done an adequate anterior vitrectomy, that is the time when you see now you have a good, nice anterior axis and a posterior axis. What you do next is basically implant the IOL in the bag. So when you're implanting the IOL in the bag, this is a 3-piece IOL what I'm using here. Don't try to dial the IOL that much. Just tap the trailing haptic into the bag, because we don't need to dial it with the posterior capsular axis. So just tap it inside the bag. So here what we have is now a nice fit IOL which is in the bag. So that's the routine cases what we would do. The other thing what you do is you could do vitrectorexis. So in such cases, when you know that the capsule is weak, I mean doing a manual vitrectorexis, doing a manual capsulotomy, a posterior capsulotomy, I mean, is difficult. So we place the IOL, and we're going behind the IOL and doing a vitrectorexis. So this is a safer procedure here in such conditions. So you have to see the morphology of the capsule before deciding what you want to do. Do a manual before it, or you would do a vitrectorexis after placing the IOL. So the IOL is in the bag, that is the ideal position, and after that we've done the posterior capsulorexis with capsulotomy with the vitrectomy machine. So this is another one now. After the IOL in the bag, we moved on to what was described by Gimbal, I think, posterior optic capture. So in children, probably we did not have a large series, and we try to compare it here using in bilateral cataract. So in one patient, in one eye we did IOL in the bag, and the other eye, what we did was a posterior optic capture. So I'll just tell you what a posterior optic capture is. So in this is one of our cases here. Of course, we dilated it with the intracameral mid-atic. So I'll just go further and tell you. So after the anterior capsular axis, we are just removing the lens matter as we would do in a routine case. And once the important thing after removing the lens matter is the posterior capsulotomy. So the posterior capsulotomy has to be larger. One second. So the posterior capsulotomy has to be larger as you would do in a routine case of IOL implantation when you're intending it to put in the bag. So if you see here, it's a large posterior capsular axis. We haven't done an anterior vitrectomy here because we're going to place the IOL, the optic, in the Burgess space. So we put the IOL in the bag, and now we're going to gradually, you can say, just nudge it behind the posterior capsule. So the indication for a successful capture is that you have an oblong or a diamond-shaped posterior axis. You can see here the diamond-shaped posterior axis. This is the axis. So it's locked here at the optic-haptic junction. So you have the haptic in the bag, and the optic is gone behind the posterior capsule. So with that, what happens is there is going to be fibrosis along all the anterior and posterior capsule like a sommering ring here. So that's what we're going to achieve. This is what we achieved here. You can see here a very nice fibrosis occurring between the anterior and posterior capsule. Remember, no anterior vitrectomy was done here. Whereas in this eye, the anterior vitrectomy was done, the IOL is in the bag. You can see the anterior axis, the posterior axis, the IOL is in the bag. And after maybe a few years down the line, you have a nice sommering ring. There is no visual axis obscuration. So without an anterior vitrectomy, when we did the capture, there is no visual axis obscuration because everything is sequestered in the bag, because it's sealed. The bag is sealed because there is nothing in the bag. The optic is behind the posterior capsule. And if you see here in the bag what's happening, there is lens matter proliferation, even though it has not reached the visual axis. So that is the advantage of doing a posterior optic capture. That's the second place where we can place the IOL. The third thing is, especially in cases of ophthalmos, when you have those bags which are large, and if you try to place an IOL in the bag, what really goes wrong is with a posterior capsulotomy, the IOL can just move about left and right, and you can have a decentered IOL. So in such cases, you can do an anterior capture. Anterior capture means the haptics are in the sulcus, and the optic goes in the bag, which is with a posterior capsulotomy. So I'm just going to end this video here by showing you that the indication for a good capture is, again, what you see is a diamond-shaped anterior rhexis. You can see this diamond-shaped anterior rhexis here. And post-op, you can see here the visual axis is clear. That's the posterior capsulotomy, this small circle, and you can see this diamond-shaped or the oblong anterior rhexis. So the haptics are in the sulcus, and the optic is in the bag. So this is another way you can place the IOL in cases where you have maybe large eyes. Now coming to something new which was being discussed in the previous presentation, what is the role of imaging in deciding IOL implantation? Earlier, what did we say? We said, fine, axial length more than 17, corneal diameter more than 10, or if the age is above 6 months, you can implant the IOL. But yes, there are cases where you can implant the IOL, where such agreement is not there. And also there are cases where such agreement is there and you might not be able to implant the IOL. So I'll show you two scenarios here. You have a 1.5-year child with an axial length of 21.5. So fairly good axial length. Corneal diameter is 10, but the cornea is steep. So the patient has a left eye PFV and a clear right lens. So the right lens is clear, and you can see here the cataract. This is a persistent fetal vasculature. Now if you see what the diameter of this capsular bag is from here to here, it's about 6.7 millimeters. So usually what you do is, it's about 8 millimeters when you can easily implant an IOL in the bag. Because your lens size, your bag is small, and the IOL is too big, so it will lead to tearing, and ultimately you'll have to get the IOL out. So what can you do in these cases? Well, what you can do is something this. Because it's unilateral, and in Indian condition, the contact lenses are a big issue. What you can do is something known as a bicapsular capture. So you have a good sulcus. So you put your haptics in the sulcus, what we've done here, and you get the optic behind the posterior capsule. So posterior optic capture was getting the haptics in the bag and the optic behind the posterior capsule. In bicapsular capture, it is your haptics in the sulcus and the optic is going behind the posterior capsule. So you can see here both the anterior and the posterior capsule are oblong. So that's the indication. And if you see here, you have a nice sommering ring here. You have few pigments on the IOL, which can happen in any child with surgery, and the visual axis is fairly clear. So we were able to rehabilitate this child in a unilateral case where otherwise it would have been difficult, or you would have complications had you tried to implant an IOL in the bag. So that is how imaging can help us. The other case, again, you have a 3-month child with an axial length of 18.2, fairly good. Corneal diameter is okay, 10 millimeters. Now, according to biometry, you can implant the IOL. But according to the bag diameter, you would avoid. So you can see the bag diameter. If had this been just based on the biometric values, we would have gone in for implanted an IOL with a good 18.2 and a diameter of 10 millimeters. But when you did the UBM, you can see it's hardly 6.2 in both the eyes. So that's the size of the capsular bag. So in such a small bag, you really don't want to implant an IOL because it will lead to complications. You'll have to take out the IOL. So that is how imaging is helping us. So this is another child, a 6-month-old child with bilateral cataract. Again, it was a UBM-based decision to leave the child aphakic, even though all these parameters were normal. You can see the corneal diameter is 10, fairly good. And basically, the axial length is 19.5 and 19.6, a fairly long eye. So basically here, had you not done this UBM, probably you would have gone and implanted the IOL because you have good corneal diameter and good biometry, and the child is 6 months. But when you did the UBM, you can see how small the bag is. It's just about maybe 6 millimeters, 5.7 to 6 millimeters in both the eyes. This is one eye, and this is the other eye. So this is the UBM measurements what we had, and this helped us to basically plan our IOL, and you can say leave the child aphakic rather than go and implant the IOL. This is just to show you the intra-op OCT what we do, sometimes just to know the morphology of the lens, how it is, how the posterior capsule is, and whether it's membranous or white and all these things. We'll discuss that's a later, that's for something later. So basically, that's what was being discussed. That's what probably it will be published soon, this paper, which shows that how imaging is going to help us in the future when we have to decide for placing an intraocular lens in children. So basically, I'd like to conclude here by saying that primary IOL implantation is a good option when considering pediatric cataract surgery. It should be avoided in selected cases. Conventional placement of IOL in the bag has issues with visual axis opacification and secondary glaucoma. Refinements in techniques such as posterior optic capture have been shown to be better. Anterior optic capture stabilizes the IOLs in eyes with ophthalmos. Bag in the lens is a promising technique, but is limited by its availability. That's universal now. It's there in Europe only. And now what we are coming up is that UBM is a good imaging tool to support your planning. Thank you.
Uh, Thank you, Dr. Jaspreet, for excellent presentation. And you have told something new that particularly UBM, capsular bag size. Because till now we used to say that what is the axial length of the globe, what is the corneal diameter, and this is something new also because many of the people, they are not considering the capsular bag size while implanting IOL. So thank you so much. I think we can have discussion little later because our time is 3 more presentation. Now I will request Dr. Srijna Adhikari. She will be giving the keynote address dealing with inflammation in pediatric cataract surgery. Dr. Srijna Adhikari is professor and head department of pediatric ophthalmology and strabismus at Tilganga Institute of Ophthalmology, Kathmandu. She did her fellowship at Storm Eye Institute, South Carolina. I also did from the same place. I was there for 2 years.
With Dr. Abby.
With
Yes.
Dr. David Apple and Dr. Amy Wilson.
Yes.
And she has a lot of, I think, publication, 50 publication, and she's current president of Nepal Pediatric Ophthalmology and Strabismus Society. So please go ahead with keynote address.
Thank you so much, Dr. Jagat Ram and the organizing committee for this invitation. I would like to talk a little bit about how we deal with the inflammations in pediatric cataract surgery. There is no conflict of interest. So inflammations after the pediatric cataract surgeries, as challenging as the decision on timing of surgery to put or not to put IOL, that's what we just discussed, and the power calculations, visual rehabilitations, and the surgery itself. So we all talk about all these things, but the inflammations that we have to deal with the pediatric cataract surgery is less talked about, and sometimes even after an uneventful, excellent cataract surgery, at times it gives a headache for many weeks for the pediatric cataract surgeons. So why the inflammation is more in pediatric cataract and why we are always worried about that? Because there are some studies that show that even without the cataracts, even without the surgery, the inflammatory indicators are more in the children with the pediatric cataracts than the adult ones. And also after the pediatric cataract surgery, also it is more in the pediatric age group than in the other age group. So even without the surgery, the inflammatory indicators are very high. So these all leads to the very high inflammatory reactions in the pediatric patients after the surgery. And there are some other causes also, like immature blood-aqueous barrier in the children, and of course one very important, poor adherence to the medications, and exposure of the lens protein to the rest of the ocular structures. Sometimes even if the smaller remaining cortex, cortical matter in the pediatric cataract surgery, it leads to a lot of inflammations compared to the adult cataracts. And remaining viscoelastic materials, of course, and intraocular lens implantation. It has shown that with or without putting the IOL, the studies have shown that the inflammation is more in the pseudophakic groups. So there are different grades of inflammations that can occur, like one is antechamber, simple antechamber reactions to toxic anterior syndrome, and then after that fibrinous exudates and membranes, and which is the most severe one is the endophthalmitis. So we at times face all these inflammations in pediatric cataract surgeries. And posterior membranes and PCOs, usually I feel that it's very easily taken care of, because if you do very nice posterior capsulotomy and anterior vitrectomy, usually PCOs are not very frequent. But the anterior chamber reactions and fibrinous exudates are more frequent, and it is very difficult to deal with those reactions after the pediatric cataract surgery. And more often it leads to pupillary block, anterior synechiae, raised ICP, raised IOP. So these are all the things that leads to after the pediatric cataract if there is a lot of inflammation. So and what is the risk of increased inflammations? Of course, the juvenile idiopathic arthritis associated cataracts, uveitic associated cataracts, traumatic cataracts, post-endophthalmitis cataracts, or aphakia if after the endophthalmitis, if it has lensectomy has been done, and post-vitrectomy cataract. In those aphakia or cataract, in those cases, if we have to do the surgery later, then these are the increased risk of inflammations. So we had a small study done in our institute, and which showed that the complications after the pediatric cataract surgery, the common was the fibrin one. We got around 19% of the cases of the pediatric cataracts having some kind of complications, and on the 4th post-operative day, the highest, the fibrinous reactions were highest in the 4th post-operative day. So there were other associated factors like the age more than 4 years, and then accompanying parents when the mother was accompanying the child, and then the socioeconomic status, lower socioeconomic status were associated with the inflammations or more complications. That also shows that adherence to the drug is also very much important in pediatric cataract surgery. So how to approach or deal with the inflammations in pediatric cataract surgery? There are different stages like pre, intra, and post. All these steps are equally important. In pre-operative, we have to find out a very good history, if there is any associated systemic illnesses or not, anterior segment examinations, if there is any associated other comorbidities are present or not, and of course posterior segment evaluation should also be done. And GIA is cataract is very frequent in GIA, and we commonly encounter this problem. And the risk factors in GIA for the development of the cataract is posterior synechiae, and then the corticosteroid itself, due to the inflammations or corticosteroid, both can give rise to the cataract formations, and then active ongoing inflammations, of course. So GI we have to deal with very cautiously, and peri-operative period is very important. The inflammation should be reduced, and at least there is 3 months of inflammation-free period before we should intervene in the GI cases. And then intraoperative also less manipulations. The synecholysis should be done very well prior to the cataract extractions, and we can use viscoelastics, whether for the dissections of the synechia, whether to implant or not to implant. In these cases, we have to do clinical decisions. Sometimes the inflammations is so intense that it's better not to put the intraocular lenses. And then comorbid pathologies also has to be dealt with. So, and then the corticosteroid, of course. Then the post-operative period is also important, because there are so many post-operative inflammations are associated with this, like CME, epiretinal membranes, hypotony, and then that's why escalations of the immunosuppressive agents should be done, and it has to be very close collaborations with the rheumatologist. And the tapering is very, very important in these kind of situations where the drugs should be tapered very cautiously, the steroid not like the other usual cataracts. And the traumatic cataract now is also a very poses the high risk of inflammations post-operatively. There can be injuries, lens ruptures, bitter graft, anything can happen in post-traumatic cataract. So and that's why we have to, at the time of repair, if there is an open globe injury, all the lens materials that should always be removed very thoroughly, so as to prevent the adhesions later. And the secondary IOL can be kept usually 6 weeks after the primary repair, along with the removal of the sutures. So we cannot wait more than 6 weeks because there is a chance of amblyopia. But in older children, we can consider waiting a little longer. And if there is no bag or IOL, the scleral fixation can be an option. But if the smaller children, no bag, no IOL, then leave the child aphakic and then do the visual rehabilitation accordingly. Of course, contact lens is an option, but for us in our setup, contact lens is very, very difficult in terms of hygiene, parental counseling, and all those things. So now, how to reduce the inflammations? We can do less manipulations of the iris. If there is a poor dilatation, use adrenaline or the dilating drops, but less use of pupillary stretch. Gentle synecholysis, capsular polishing helps a lot. Cleaning of the viscoelastics, very good cleaning, and intraoperative corticosteroid like triamcinolone, dexamethasone can be used. And endophthalmitis, if there is an endophthalmitis case and if the intravitreal injections only were given, then cataract can be the possibility. But if it is lensectomy, vitrectomy was then there is an aphakic state and we have to put secondary IOLs. And so in these situations, we have to wait at least 3 months post endophthalmitis state to do the interventions, either to do surgery cataract or to put in secondary IOL implantations. And of course, topical and oral corticosteroids has to be given. Now, these are the conditions that I talked about are some of the special conditions where inflammation is more. But sometimes even with the regular cataract surgeries, after the cataract, it is always in the state of inflammation. So what we do is we do the corticosteroid therapy, and then with a very cautious tapering dose, and cycloplasics are always used, and antibiotics along with that. And usually third to fourth postoperative days, so it is not seen in the first postoperative day, but later on the inflammation parameters increases in the anterior chamber. So this is the day, fourth to fifth or from third to fifth postoperative days are very, very important, and then follow-up should be done accordingly. Another very difficult situation sometimes we get is the toxic anterior segment syndrome, in which it's very difficult to deal with. We have to give corticosteroid and intravitreal the subconjunctival injections, and and when the child is small, it's very difficult. It has to put the child under GA for all these injections, and also it has to be dealt with very cautiously. And so there are different studies which have shown very good results with implantations, intravitreal dexamethasone implantations, and then another one is a Di-Flu prednet topical versus the prednisolone. So there are some of the things that can be used to reduce the inflammations, like intravitreal implants or any other, apart from the prednisolone, other drops. And then another one is either tricot subtenon, which many of the practitioners use, tricot intracameral or triamcinolone subtenon. So the studies have shown that subtenon is also as good as the other ones, but the one thing, in fact better one, but we have to deal with the increased intraocular pressure. That is very important, and we have to be very careful on that. And one very interesting that is that study was done by my mentor, Dr. Ed Wilson, and there was an insert, the dexamethasone insert, that is Dexena in the pediatric cataract surgery, that is intracanalicular, which has also shown that there is a very less use or no use of post-operative topical drops after the pediatric cataract surgery. This is a very interesting study, but it's still not widely used. So these are some of the things that we have to be careful whenever we deal with either normal pediatric cataract surgery or the high-risk pediatric cataract surgery. So I just wanted to show a video in which if you don't do at the time of repair the good lens cleaning or the lens removal in the perforating eye injury, then you have to land up with this type of situations where there is very severe reactions and severe fibrosis, and it's very difficult to put intraocular lenses also, and we have to deal with the membranes and fibrotic tissues after that. So I removed the sutures in this case at the time, and then the only thing that I could do was to remove those membranes and leave the child aphakic, and then later did do the visual rehabilitations. So even the contact lens is very difficult in these situations, and where to put IOL is a very difficult thing to do so. And then another thing, this is an inflammatory cataract. So even the pupils are small. If you remove the synechia properly, then there is no use, no need to use pupillary stretch, because I use very less pupillary stretch during the pediatric cataract surgery. And then most of the time, if you remove the synechia, you can have a very good dilatation of pupil, at least good enough to do your pediatric cataract surgery and then put IOL and all those things. So there is you can just avoid the pupillary stretch in these situations. And then another one is another inflammatory cataract post-traumatic inflammations, and then we have to remove with the vitrectomy cutter. So most of the cataract surgeries that I do is bimanual vitrectomy. Even the anterior capsulotomy, posterior capsulotomy, everything I do with a vitrectomy cutter. So thank you so much for your attention. And again, also I would like to invite you all for our annual conference in Nepal in November. You all are welcome for that. Thank you so much.
Thank you, Dr. Sarajana, for excellent keynote address on dealing with the inflammation during cataract surgery. I think there is no discussion on the subject, but I can say, in addition to what you said, now presently for the last, I think, 3-4 months, there is a TAS. There is some viscoelastic which is producing TAS. So we have to stop such viscoelastic.
Yes.
That is coming up, it is producing intense inflammation.
Yes. TAS is a very difficult these days. Even for last few months, we are having that. So
I think there is a viscoelastic which is producing TAS.
Okay.
So, and it is producing even hypopion.
Yes.
And they are treating it just like endophthalmitis.
Yes.
So, because we are short of time, we will go to the next lecture.
Yes.
That will be by Dr. Love. He will be speaking on management of pediatric subluxation. After that, there is one more.
Thank you, sir. And I think we'll go straight to the subject. And when we are dealing with pediatric lens subluxation, what we are dealing with is a non-traumatic, and generally it is a progressive lens subluxation, and which leads to high myopia and high astigmatism. Visual acuity drops as the lens margin approaches the visual axis or the pupillary area. So we have to decide when to operate and whether to operate or not. And that decision, I think, will be based on the age of the child and the visual acuity. So the surgical options that are available in these cases, and we will go through the merits of all these surgical options later on, but these are some of the options. One is preservation of the capsular bag, and in which either a Ahmed segment or Sioni ring can be used, or a scleral fixated IOL with sutures or a glued IOL. And most important is that most of these are older children, and they will be more than 8 years at least. And when we present the first case, what you see here, that capsulorhexis is probably one of the most difficult steps in pediatric subluxations. And we have to, with a mobile lens and the elastic posterior anterior capsule, we have to put traction on the capsular bag so that we are able to complete the anterior capsulorhexis. And once it is done, then we see the cortical aspiration is done after implantation of the CTR, and the lens is placed in the bag. And single piece or 3-piece lens, it's the choice of the surgeon, and if some of the cases you will see a single piece, and some it will be the 3-piece lens in these demonstrations. And if the capsulorhexis is decentered, we can put a relaxing cut, and and then the MH segment is used to fixate the bag. In this, you can see it is MH segment is slightly more bulky when compared to the Sioni ring, but the advantage is that manipulation inside the bag is much less, and a 9-O-proline or Gore-Tex suture should be used, but not 10-O-proline, because over a period of time it may cut through the tissue and the lens may subluxate again. So we'll go to the next option, which is the Sioni ring, and in this case you can see this is almost more than 180-degree subluxation, in which again the capsular hooks are used to complete the capsular axis, and then once it is done, towards the subluxated side of the lens we make a scleral pocket and scleral flap. And in this, you can see the Sioni ring is sutured, and the problem is rotating in the bag. So here you manipulate the bag more when you are putting in the Sioni ring, and if you can do it comfortably, sometimes it becomes very difficult. In one of my cases, due to the small size of the bag, the ring came out in the sulcus again, and then once it is in the anterior chamber, it becomes very difficult to reinsert again. And as we did in the previous case, it is sutured to the sclera and the lens is well centered. And most of these cases are older children, so we try to avoid a posterior capsular axis, and if needed, early YAG in post-operative period as soon as you see indications of posterior capsular opacity. So next, I will go to a third option in similar case. In this, what had happened, the other eye we had used only CTR and the lens had got well centered. So I was not prepared with a MH segment on or a Sioni ring in the other eye, and to my surprise, after the lens was implanted, the CTR was implanted first and then the lens. So what you can see here in this, a 3-piece lens has been implanted in the bag. Posterior capsular axis is done, and after that we notice that still the lens is grossly decentered. So what one innovation I did in this case was just use a 9-O-proline, and that pierced the capsular bag with using the CTR as the anchor, and we sutured the CTR to the sclera, and after that the lens got quite well centered. This is one option, but has the risk that slightly more manipulation can tear up the bag totally, and the whole thing will become unstable. So now this is what I have been leaning towards lately, because all these capsular fixation bag over the long period of time, the lens starts giving way from the other side also. There is a lot of fibrosis, though almost all of them have been maintaining 6/9, 6/12 vision, but when you see it through the slit lamp, you always fear that what would happen to this bag over a few years down the line. So a safer method can be leaving the eye, doing a lensectomy and leaving the eye aphakic for a future scleral fixated IOL at an older age. And a neatly done lensectomy may, and a good compliance with spectacles after that may give a equally good result. So this is one of the surgical options we have in subluxated lens. Next is, what if the bag subluxates? As I had told earlier, that it is a progressive disease, so over a period of time, the bag may give way from the other side and the lens may again decentered. But since the capsule is already fibrosed, a very simple method can be used for fixation of the bag, in which the haptic within the bag can be used as an anchor for suturing. And as you can see, we pierce the bag at the haptic optic junction, and from there it is brought outside and sutured to the sclera. So this is another option. With paucity of time, I think I will skip this beyond this. And final option, what we have is a scleral fixated lens. Again, preserve it for older children, maybe around 12 years, 15 years. If you are operating, you can do a scleral fixated lens as a primary option, in which a lensectomy is done. And as you can see, this is almost 270-degree or more subluxation. So we did a lensectomy, and care has to be taken that cortical fibers don't fall in the vitreous cavity. So first make a opening on the anterior capsule and anterior side of the lens, and then probably from the equator side we start removing the lens, and the attached portion of the lens is taken off last. So in this case, as you can see, unfortunately I'm not able to see the time bar, and I'm not able to fast forward it. So after you can just indent the sclera little bit to see that the attached portion, whole of the bag is removed, and then after that, using a 9-O-proline scleral fixated lens can be implanted. And these children also, if you do in a neatly done surgery, they do quite well. And that's all from my side. Thank you so much.
Thank you so much, Dr. Love, for your excellent presentation. And I think you have shown absolutely stunning type of some of the subluxated cataract.
Thank you, sir.
So this is just outstanding.
Now I'll request Professor Jagat Ram for his presentations on dealing with the most devastating scenarios in pediatric cataract. Probably you require a lot of experience to deal with that and tackle them in a successful manner. So with that, I'll say presentation ready. Yeah, Professor Jagat Ram, please.
Thank you, Dr. Jaspreet. I think a question why we kept for the end, because we may not exceed the time. That's why we will discuss after my presentation. So I will be presenting surgical tips and tricks for complicated pediatric cataract surgery. As such, also pediatric cataract is complicated. Even it looks simple, but it is very, very complicated. These children present to us with visually significant cataract. And our goal in each eye is to have a clear visual axis and long-term visual rehabilitation. I will be showing some of the videos, tips and tricks for pediatric cataract surgery. Each of the case we have to prepare very, very well and plan for surgical procedure. While child come to us, we have to diagnose whether it is a cataract, simple or with PHPV or any of the other issue. Plan surgery, sometime we innovate, execute the procedure, and most importantly, we have to follow up these patients for long time. This is one single surgical procedure in single clip where I am showing a simple pediatric cataract surgery basic step, which initially very elegantly Dr. Parul and even Dr. Jaspreet Sukhiza has shown. Here we stain the anterior capsule so that we can precisely make continuous curvilinear capsular axis. Size of the axis is kept around 5 millimeter or so. This is followed by hydrodissection, removal of the cortex from the capsular bag, and then primary posterior capsulotomy. Initial nick is by needle cystitome. And then slowly and steadily with Utrata forceps, we create approximately 3.5 millimeter posterior axis. Almost minimal or no disturbance in the vitreous, but limited anterior vitrectomy we do in the zone of posterior rhexis. Then each of the child we implant hydrophobic acrylic IOL into the capsular bag, or it can be implanted as my co-instructor Dr. Jaspreet said, optic capture or other modalities. Coming to other complicated pediatric cataract cases, we have so many: PHPV, buophthalmos, microphthalmos, juvenile idiopathic arthritis. This is one video clip of a posterior lenticonus 2-year-old child with bilateral posterior capsular dehiscence. You can see on the OCT on the side. We knew that there is a pre-existing posterior PCR. Rhexis is done approximately 5 mm in size, limited hydrodissection, removal of the cortex from the capsular bag, and then filling the bag with the viscoelastic, and then implanting IOL into capsular bag. And then limited vitrectomy in this pre-existing PCR. This is triamcinolone which is being removed. And this is after 8 months, there is thickening of the rhexis margins. This is the anterior segment OCT. Then come juvenile idiopathic arthritis. As Dr. Srijna discussed inflammation in children, this is one of the such cases. And adequate pupil should be there before we proceed with the cataract surgery. So here we are implanting Malaysian ring and this will give a excellent dilatation of the pupil and removal of the cortex from the capsular bag, little polishing, and then implanting IOL into capsular bag and removing the Malaysian ring, and removal of the viscoelastic is extremely important. A little peripheral PI was done here. We do very selectively. This is another child with the lenticular coloboma with the high corneal astigmatism. Posterior synecdoche were there, so synechotomy was done. Then continuous curvilinear capsular rhexis. And then capsular hooks were placed to the capsular rhexis margin. After hydrodissection, removal of the cortex from the capsular bag. And then our aim is to make the capsular bag central, and here we used one eyelet Sioni ring, and at the same time used toric IOL. Callisto was used in this case, and then surgery was completed, and at the end of the surgery you can see before and after well centered IOL in the capsular bag. And then we have this child with the double crystalline lens. This is also one of the most complicated situation two lobe of the lenses and then two continuous curvilinear capsular axes. And the removal of the cortex, and this was a customized IOL which was implanted in this child, made by eye care group, and this child received excellent outcome. Amblyopia therapy was instituted, and this child was followed up for long time. Then comes another difficult situation, that is PHPV or persistent fetal vasculature. Cauterization of the vascularized posterior capsule, and this was converted into posterior axis. It was so thick, it was cut with the, and then cauterization of the stalk. And then vitrectomy. And then IOL was implanted here. It was captured. So with this, I come to the end of the presentation. If there is any, because I want to cut short my presentation because previous session was late and we also started a bit late. So any question for my previous speaker and for me? Yeah, please.
Can you please use the mic?
Little
you
louder
please
on
use
the
the
mic
mic?
side, please. There is a mic there.
Yes. Okay. GI, so 3 months, at least 3 months should be there, and yeah. Yeah. Yes, 3 months and quiet as well as under the immunosuppressions and corticosteroids. That is because of lenticular. It's yes, it's not corneal. Yes, yeah.
It depends on the vision of the child. How much was the vision?
Yeah. Subluxation, I think, is because of the lenticular subluxation. It's not the corneal. Astigmatism is not corneal, but it's a lenticular astigmatism, usually in subluxated lenses. Yes. Yes, you can remove the intraocular, just like
You can
the
just leave it aphakic also.
aphakic
That is the
also.
easiest way to
Yes.
do it, because
Scleral fixation. The other option is to do the lensectomy, anterior vitrectomy very nicely, leave the child aphakic. That is also a very good option. And since it is bilateral, it is easy. But if it is unilateral, then that is a different scenario. And then you can put scleral fixation IOL later, after 12, 13 years of age. Yes, yes. And sometimes in subluxated lens, if the axial length is also enlarged, then in that situation it's more easier to do the visual rehabilitation, because the power of the lens will not be very much hypermetropic. It will not be very high plus. So
Yeah. So yeah. So basically, the infant aphakia treatment study has shown that age is the only criteria probably where you can have secondary glaucoma and visual axis opacification later. So if it's less than 3 months, probably just leave the child aphakic. Above 3 months, if you have a UBM, probably go ahead with it. But again, they have shown that the chance of reoperations are very high when you place an IOL. So above 6 months, you can place an IOL. Less than 6 months, it's every patient is different. Ye- So yes, so earlier the consensus was do not implant below 2 years, but now it's do not implant less than 6 months.
Thank you very much. With this, we come to the end of the session instruction course. I am thankful to all the faculty members, Dr. Srijna Adhikari, Dr. Love, Dr. Jaspreet, Dr. Savleen, and Dr. Parul Chawla Gupta for contributing for this instruction course and keynote address. Thank you very much. And yeah, photograph.